Well, hello, this is Tim Bardell again, part 7 of my series on respiratory therapy for nursing. This is going to be very short. I'm just trying to build up to a big topic that I'll be doing next in section 8. Part of the way that lung disease is classified is by being either restrictive or obstructive. And the best way to think about this is that if this is a continuum, restrictive would be on one end of this spectrum, and obstructive would be on the exact opposite end of the spectrum here. There's nothing similar about either one of these. They are as far apart as you possibly can be, because with restrictive lung disease, again, it's a disease process of inspiration, meaning you have difficulty getting the air in. Exhalation is no problem whatsoever, whereas in the obstructive diseases, it's the exact opposite. They can get the air in, they just can't get the air out. Ventilation, when we take a breath in, it takes muscular work to do that. You're contracting your diaphragm. You have accessory muscles of ventilation that you could use. The diaphragm is the primary muscle of ventilation. The accessory muscles would be like the intercostal, the pectoralis major, the sternocleidomastoid muscles of the neck, your scalene muscles in the back, and we only incorporate those when we're under a great amount of stress. So for instance, I'm relatively healthy, so if I started jogging and then I went into an absolute sprint, I would incorporate all of those muscles for inspiration. Exhalation then is passive, unless, again, in a sprint, I may use my abdominal muscles to try to force the air out so I can breathe faster and deeper. With the restrictive lung diseases, you will see a high work of breathing in the struggle of trying to get air in. And again, the types of restrictive lung diseases that you're going to see, pneumonia, atelectasis, pneumothorax, those kind of things. And the restrictive lung diseases, they are acute. The patient is fine, and then something traumatic happens, and it's an acute process where you're going to see it now, happening right now, and it needs to be treated. This can happen to anybody of any age range. The obstructive diseases, things like COPD, things like COPD, that you have two different components. You have a chronic bronchitis effect for it, or maybe emphysema. And there's actually two types of emphysema. There's panlobular emphysema and centralobular emphysema. This is very chronic. It's a slow, insidious process that takes a long time, years, decades, for the obstructive diseases such as COPD to actually show itself. Most people lie right here in the middle. We're healthy, normal. We could move into a restrictive process if we got pneumonia. It would take a long time to get into the obstructive components. The worst case scenario that you could ever see is a patient who has a chronic obstructive disease component, like COPD, that gets pneumonia, because now you've covered the entire spectrum, and it is very, very bad for a COPD patient to get pneumonia. You have to try to ward that off at any length. Patients who get COPD over 10 years, 20 years, 30 years, that end up with pneumonia, oftentimes it will be their demise. In the next section, what I really want to focus on is COPD. Thank you very much.